So hi, good morning everyone. I think after
Nimrata Dhami.
Yeah, thank you ma'am.
Dilemma in ocular surface diseases.
Yes. So I think after the surgical cases, I'm just going to take you into the little OPD dilemmas that we all see. So the first is, I would want everyone to give their inputs here. So the first is the case of delayed or was it an overlooked diagnosis? So the 65-year-old male presented with decreased vision since 6 months. He had a history of chemical fall in the right eye 2 years back. So he came to us for cataract, and as you can see, the cataract is fairly visible. But I saw these things at the limbus, and I corroborated the history that there is a history that, there has been some chemical fall. He was into agriculture things, so he said that there's some pesticide or something fell. So I corroborated that there was some limbal cell deficiency which might have happened. So the diagnosis was there was a cataract, there was LSCD due to secondary to the chemical fall, and he underwent a successful cataract surgery. So this is just to highlight what was there at the limbus. So 3 weeks later, as I followed up this case as a routine cataract post-op, I noticed something on the nasal bulbar conjunctiva. So now these lesions started, the hair loop pattern, and yes, it's a no-brainer that this was a OSSN which had developed. So this is just 3 weeks into the post-operative care. The patient is on routine antibiotic steroids and lubricants and all that is going on. So again, I saw there is a satellite lesion also which has appeared. So clinical picture was OSSN. We started the patient on interferon alpha 2B. Due to minimal slow response, I expedited the treatment with 5-fluorouracil topical eye drops. Surface toxicity was noted, but then the resolution happened, everything was fine, but this is just one corner of the picture. This is the complete picture. So any comments? Do you see a picture difference in this first picture and the picture that I showed just right now?
I think it has completely resolved.
Yes, the lesions at the limbus have resolved. So what was my learning point from this case was that, although it looked like something like an OSSN, but I corroborated the history. So actually, we ended up operating on a patient who had corneal OSSN. Corneal OSSNs are very rare, and you don't think of them. You're mostly focused onto the conjunctiva. But this was a case of corneal OSSN, and due to the surgery and everything that was going on, some surface stress, this patient developed conjunctival lesions when we started treating it. But all in all, in the end, we had a very clear picture, and the patient resolved of what he was already carrying. So this was a case of delayed or overlooked diagnosis. So this was not an LSCD, this was a corneal OSSN which was neglected. So these are, rare singular presentation, amoeboid lesions, and primary monotherapy is useful. So luckily we had a good call with this. This is just to discuss, how we can take into the medical and surgical management. I think if you want to discuss more, I can read it. Otherwise, I'll go to the next case. So the next case is, will the past reveal the present? So this 65-year-old diabetic came with redness, poor vision since 1 year, lubricants, and currently on glimipride and metformin. So this was how the corneal surface looked. There was the fluorescent stain picture is also there. And you can see there is obviously a lid margin keratinization. So this is a left eye slit lamp findings, and the BCVA was 3/60. So this is the right eye, BCVA was 6/12. You can see the corneal surface was a little better. So this is a bilaterally asymmetrical presentation. And you can see there is lid margin keratinization, surface staining you can see, and the corneal surface. So all three pictures I've taken for the right and the left eye. So I was very surprised that why is this happening. What was going on in my head was, what is the triggering factor for this patient? There is no history of any Stevens-Johnson syndrome. There is the drugs are glimipride. And what I was thinking was, is this some kind of a drug-induced cicatricial conjunctivitis? But the drug is glimipride, and in our popular understanding, gliptins are the ones which cause this. So the thing is, this knowledge helped me, and I took 10-15 minutes extra with this patient. Luckily, his attendant was very intelligent. I specifically named the drug. I kind of threw a net to catch the fish, that is there something related to that? So no history of AGMs, no history of allergy, all these investigations, CBC, ESR, RA factor, I ruled out arthritis. If there is some, allergic component, if there is some Sjogren element, nothing. But there was a history of hospitalization 2 years back, and some specific drug history which had to be probed. He said that 1.5 years back, there was a history that he was given Vidagliptin. It did not suit him, he was hospitalized. So, as you can see, that the history corroborates. 6 months later or 3 months later after that, so I believe that that small episode of Vidagliptin, when he was exposed to that drug, some surface changes set in. The patient may not have noticed it. He was a huge, I think 150 kilo, really huge guy. And sometimes they, get lazy, they delay their diagnosis, they think thodi si redness ho rahi, and they kept going here and there. So what I believed was that that one episode of Vidagliptin set in this slowly cascading drug-induced cicatricial conjunctivitis, and hence I had a diagnosis in my head now that this is a DICC case. So yes, so I asked, there's no history of skin lesions. So I believe that the episode was that he had this drug, he felt uncomfortable, he was hospitalized, there were no skin lesions. So that is how I ruled out that it was possibly, so the overlap is that something happened with Vidagliptin. It was drug-induced, you want to call it. From that point, a cicatricial conjunctivitis is the only thing that I have left with. There is no skin lesions, nothing. Yes, yes. Yeah. Yeah, right. So, yes, there is some, some cicatricial element started from that. Yes. Right. I think so. That just corroborates with. Yeah. So I think that and this case just kind of corroborates with that understanding that it does. So my options were to weigh against medical and surgical intervention. I did tell the patient that, that there is a possibility that we will treat you medically and we may need an MMG, but there is so much, I told you, it's very difficult to make that patient sit, 150 kilo guy on your slit lamp chair. So he said, I don't want any surgical intervention. We started the patient on autologous serum eye drops, paraffin-based ointments, and the patient started doing better. So you can see the LMK looks less aggressive, the corneal surface improved, and the right eye BCVA from 612 improved to 6.6. Patient was very, very happy. Left eye is 6/60. I know that this patient needs an MMG, but it's very hard to counsel him. But he said, I'm very happy. My life is back on track. The redness is reduced. There are no symptoms. So now he is on paraffin-based ointments and lubricating, and a very, very happy patient. So that autologous serum drops for 3 months, that course really helped him. So this was the magic of autologous serum eye drops. So also another case that I want to tell you is that this patient, she was a young girl who had, so this was a young girl who had neurotrophic keratitis, keratopathy secondary to viral. We did patching, we did AMT with Tarso. Still this picture linger on, so now this patient is on autologous serum eye drops. So just to, just tell the importance that these are a very important part in a cornea clinic. So as you can see, the vessels are becoming less aggressive and the corneal surface is improving. Now, next is a very interesting case of the migrating dilemma. So these are the lesions. You can see there is a pattern, a better picture, and this is the fluorescent picture. Any diagnosis which is in your head? What could it be?
Pseudodendrite.
Sorry?
Pseudodendrite.
Patterned abrasions, it could be thygosine punctate, ocular rosacea, or viral keratitis. So these were the variants in my head, but thankfully I had seen one singular case in my fellowship, and this was the printed as the cover page of IJO by Dr. Himanshu Matalia. It is a very specific variant of viral keratitis. As you can see, it starts from the limbus and it goes towards the center. Very beautifully, it is replicating how the stem cells migrate from the limbus and how the epithelium grows. So what happens is, in immunocompromised patients, commonly diabetic CKD patients, this variant of viral keratitis, I'll just reveal the name. There is infection of the HSV element or the viral element at the limbus, and as the cells grow, the virus grows and comes towards the center. This is called as archipelago keratitis. It is a clinical variant. It is an atypical variant of HSV infection in immunocompromised patients. Mostly you'll see, those diabetic CKD patients, this is very commonly seen. Unilateral, marginal variety of HSV spreads in multiple foci, radial, linear centripetal fashion as the proliferation of the limbal stem cell happens. So it's known to be recurrent, so you should avoid delay in diagnosis, and you need the support of oral antivirals. Of course, you have to look into the kidney condition as well. So as you can see, I just gave this patient ganciclovir ointment 3 to 5 times a day, and this is it, just oral, and this kidney condition was fine, so I gave him a very short course of systemic antivirals, but yeah, this patient resolved very beautifully, and as you can see, the lesions are getting better. So this was a female who had very long-standing redness, photophobia, decreased vision, chronic cicatricial conjunctivitis plus dry eye plus cataract, poor vision, very unstable. Since 2 years, she has been lingering on with redness, unable to open the eye. I could barely take a picture, very photophobic patient. So blood investigations, we ruled out, arthritis, Sjogren, IgE, all the connective tissue profile was done. I did not have much to do here. I was scared of doing a conjunctival biopsy. This is not this same patient, but this patient came to me after getting a conjunctival biopsy. I've looked at the morbidity of these patients. I was very scared to take up this patient for a biopsy. So a clinical suspicion OCP, we started this patient topically on steroids and tacrolimus, systemic oral steroids and IV cyclophosphamide. And you can see the beauty, the ocular surface started improving. So I think sometimes the clinical understanding, a little bravery, and your friendship with your rheumatologist friend who are ready to take up, a bit of a challenge and do very good, follow up with these patients. This patient started improving, the redness has improved. You can see the ocular surface is much better. Now all you see is the cataract, which needed to be improved. This was before immunosuppression. And the second picture is after the second cycle of cyclophosphamide. Interestingly, after the 4th cycle of cyclophosphamide, this right eye developed epithelial viral keratitis. So this was first time for me that I saw dendrites on the conjunctiva as well. You can see this is how beautifully sadly for the patient, but how beautifully for the cornea person, that how I could see that. So we stopped the systemic immunosuppression for a bit, for a month, and the patient started improving. And this patient, we only gave topical antivirals. So a bit of a hurdle at the 4th cycle, some viral element came up, was stopped, managed, taken care of. We delayed 1 cycle again, but after the 6th cycle, everything was done. The viral element was also, I did not have a recurrence, thankfully. This patient was operated for cataract and now has a BCV of 6/9. So a long journey. She has a thick file with us, but very, very grateful and a happy patient. And actually, I think these are your winning patients in the OPD, where you actually feel you've done something good. So just to talk about the step-ladder approach of PUK, this male presented us with this lesion. It's a no-brainer. So this is a case of Murans. So topical steroids, systemic steroids, and I did a conjunctival resection in this case, just to tell you that sometimes you need to tailor your treatment. You can give topical treatment, systemic treatment. You might have to go for a conjunctival resection, and the lesion was resolved. But some cases, like this case, I thought, that this is going to be, I might have to take up this patient for a patch graft or something. But there was already history of conjunctival resection. Everything was tried. So we started systemic and topical steroids. I did a glue BCL just to tide over the crisis. And we gave the patient, in this patient also, we gave 6 cycles of cyclophosphamide. And I had to actually do nothing. You can see the lesion started resolving. So where you think you might end up doing a patch graft. So what I need to emphasize this is that first case just needed a conjunctival resection. The second case just resolved with your systemic treatment. So we have to understand that PUK, your test may or may not come positive, but you need a very good rheumat connect, and you need a bit of a bravery that sometimes you don't have a diagnosis and you just give a cycle of cyclophosphamide and the pulse IV MPs, and the patient starts improving. So not every patient needs a surgery. At the end, all these cornea diseases, they have a very deep rheumat connect, which you need to explore and which you need to bravely treat. So this was just a tailored approach. And very importantly, we don't need to treat the reports. The reports may be misleading. We need to understand there is a thing called specificity and sensitivity. We need to treat the patient. So your reports may or may not come as per what you want, but you need to treat the patient, and these diseases beyond your understanding have a rheumat connect. Thank you.